and I can't think of anyone better than Dr. Banerjee leading the whole, peripheral vascular section of this morning. So Dr. Banerjee is a great friend of mine. I've known him for several years. In fact, he was at Iowa at one point when I was at Iowa. Dr. Banerjee is a scholar, a wonderful teacher, a great clinical investigator. He has contributed to cardiovascular medicine more than a lot of people that I know, in a very short period of time. He is a very prolific writer. I honestly would read almost a paper weekly, coming from his lab. And he has led a wonderful team. I've got to know many members of his team who are outstanding, fantastic people who have worked very hard. And I truly believe he already made a major impact in the field of cardiovascular medicine. Dr. Banerjee, you guys all know him here. He's the director of the Dallas VA Medical Center. He's an associate professor at University of Texas, Southwestern. He has been the PI of the XLPAD that made already major contributions to the field of peripheral vascular disease. He's going to be discussing with us the management of SFA CTO. Subhash?
Thank you. Thank you very much for being here. Whenever someone say good words about me, I ask them to send an email to my wife. So please do that, Nick. I will really appreciate it. It'll count a lot more. All speakers today have done a wonderful job of bringing our focus to patient quality of life. And as cardiovascular specialists, it's really important that we also focus on the vascular side of things. So my job is going to demystify a little bit peripheral artery disease. The first thing I want to do is define the abbreviation. We use a lot of abbreviations in interventional cardiology. So my abbreviation is SFA CTO. So what is SFA? It's the superficial femoral artery, and as you can see, it runs, as indicated on the slide, along the area of your thigh and supplies a very important conduit artery to the lower extremities. There are a few important things that I want to share with you pathophysiologically. It's the largest artery, it's highly dynamic, it sits in a fibromuscular canal, so it cannot do the obvious compensation when plaque builds up within the vessels. Coronary vessels can expand and compensate the plaque. Peripheral vessels, especially the SFA, cannot do that, and therefore it leads to a large number of total occlusions. There has been a 15% rise annually in the number of CTO procedures. So SFA CTO is something that we encounter in routine practice. Going back to Manas's slide, and before I jump into the case, you can choose to be a coronary CTO operator or not, because 8 to 18% of coronary lesions present as total occlusions. However, 55% of peripheral lesions, especially in the SFA, are a CTO. So it is obligatory for an endovascular interventionalist in the peripheral area to be knowledgeable about peripheral CTO interventions. And this is a case where we took a patient and opened up the CTO with stents. And as you can see, there are two elements to this procedure. One involves crossing of the CTO, and the second involves stenting of the CTO, or defining a primary or delivering a primary final therapy with either balloon or stent, in this case with a stent. So my talk is going to revolve around two things. If you look at SFA CTO, there are two components. Crossing the lesion, because there is no vessel to guide you, and the second aspect is defining the definitive therapy, which can either be with balloon treatments or with stents. Today my talk is going to refer mainly to drug-coated balloons and drug-coated stents, and on the crossing side towards using a $30 wire and a catheter, or a $1,200 specialized CTO crossing device. There are not much data about this, and this is a long list of wires and catheters. To your left is the crossing devices, and to your right are the guide wires, and there are lots of brands. I won't go into them. And the XLPAD registry has really contributed towards studying this, and I'm going to share some of this data from our own registry to which my colleagues have contributed. First, definition. There's a lot of confusion about how to interpret a myriad of studies, so our contribution first was to write a paper about defining how to define success. First is that if you take a procedure and you take a device and the device goes through the lesion on its own without any other support, it is going to be defined as primary technical success. If you succeed in crossing the CTO and also have a less than 30% residual with a stent or a balloon, that will be called procedural success. If you are unable to cross the lesion and you utilize a second device, it will be called secondary success. Or if you use a re-entry device, for example, you end up on the side of the vessel and you have to deliver the wire down to the main vessel, it will be called provisional success. I want to stop here to thank that all my colleagues listed and many not listed who have contributed to the XLPAD registry. Is the largest SFA adjudicated core lab registry in the United States right now, with over 1,700 procedures listed in the registry, which all have been independently adjudicated by our team. We owe our gratitude to Dallas VA Medical Center, Dallas VA Research Corporation, and to my colleagues in support from University of Texas Southwestern Medical Center. Here are the primary results. First of all, you can see that more operators chose a wire catheter over a crossing device. If you chose a wire catheter, you had to switch more number of times to a crossing device or use a re-entry device to achieve provisional success, which was lower with the CTO devices. In terms of primary technical success, that means if you started with a device, you were able to cross the lesion with the primary device, it was higher with the crossing devices. However, overall procedural success was no different. That means that if the wire somehow failed in some situations, you were able to bail yourself out with a re-entry device. This obviously brings into question what is the overall cost-benefit ratio, and that I will not be able to address in this presentation. I'll indulge you over coffee, over lunch, and over the break. So get to me about cost benefits. In terms of 30-day endpoints, as you can see, there are no statistically significant differences. And also at 12-month endpoints, there are no statistically significant differences. In terms of patient outcomes, a reduction in Rutherford category indicates better resolution of symptoms. So as you can see, with both the wire catheter and the CTO device, there is good resolution of symptoms. And the ankle brachial index is an indicator of perfusion to the lower extremities, and that also is better, with equal and better with both the devices. There is also a question that, if you can cross the lesion with a device, or if you enter the subintimal space, that means you go outside the lumen of the vessel and you have to use a re-entry device to direct yourself back, is there a difference in outcomes? And as this slide shows, there is absolutely no difference. Also, between a myriad of devices that I showed some pictures of, there is absolutely no difference which device you choose as long as you are good with it. So these are some take-home points that I would like you to remember. We have published a huge scheme. It is published in the Journal of Invasive Cardiology, how to place each of these devices in their appropriate place, depending upon the type of lesion. Of course, this gathering is not conducive to discuss each of these types of lesions. However, each device, depending upon your proficiency. So I advise people and labs to get hold of 1 or 2 devices and get proficient with it. We have published some important papers, ourselves and our colleagues and our fellows, and there are 3 important things I want to share, apart from the fact that this is very prevalent. That distal embolization during crossing CTO is a real phenomenon. Though the vessel is occluded, the main lumen of the CTO, apart from the proximal and distal cap in the peripheral vessel, is fully loaded with thrombus. So once you release that, you can have significant distal embolization, and Dr. Nicholas Shamas has published landmark articles in this area. Second is that because you need a scaffold to secure the success from crossing, you require generally a stent. So stent-based procedures are highly prevalent, and that leads me to the second part of my talk. I'm going to address 2 therapeutic devices. On this slide is the drug-coated stent data from the Zilver PTX trial. It has made it is increasing in use, and it is loaded with paclitaxel, as you can see. In this study, there were only 27% of CTOs. However, for intermediate to moderate complexity of lesions, drug-coated stents did better than bare metal stents. Recently, we have 2 drug-coated balloons. One is called the Lutonix balloon, and one is called the Impact Admiral balloon from Medtronic that was just approved a few weeks ago. I want to show you this cartoon onto the very left of the screen, where you can see with drug-coated balloons, you have to be very careful of not missing the lesion. That means that if you pre-dilate the lesion with a conventional balloon and you then apply the drug-coated balloon, but the delivery of drug completely does not cover the treatment area of the conventional balloon, you're not going to see good success. And therefore, in this trial, the IMPACT SFA trial, the drug-coated balloon fared remarkably better. In conclusion, I want to share with you 4 key take-home points. Number 1, a primary wire catheter strategy is selected more frequently by operators, number 1. Number 2, we did not find in our study an overall patient-based difference in terms of outcomes. However, primary technical success was statistically higher with a CTO crossing device. Number 3 is that stent use is significantly higher with CTOs. And finally, however you choose to develop the expertise of your own or your lab, you can deliver reproducible success in improving patient quality of life. So those are 4 take-home points. And before I leave the podium, I could not leave without thanking a few important individuals. So it's a slide that is quite busy, but I want to indicate Dr. Berlakis, who is my friend and colleague. I want to acknowledge Dr. Clark Gregg, the director and the chief of staff of the Dallas VA Medical Center. I want to acknowledge Dr. Joseph Hill, without whose support and recognition and guidance I would not be here today. I also acknowledge all my colleagues from the XLPAD Registry, University of Texas Southwestern Medical Center, and members and colleagues of my cath lab staff, and finally, and not least, my patients. Thank you very much for paying attention.